Thank you.
When I read through this, this is all about, to me, this is all about the app and whether we want to cover the app. And I'm following all of it until I get to this last sentence in blue. And then you start pulling in coverage of the medications. And then,
So we
like, help me pull this all together.
So a few years ago, when we moved insomnia to a covered line, it was because CBTI had such evidence of effectiveness.
Okay.
There was a lot of concern though that if we did that, basically all we would be doing is paying for Ambien, Zolpidem, which has a lot of concerning side effects. So we wrote this guideline that you could get a short prescription for a septic hypnotic like Ambien, or I don't want to pick on that. There are other more expensive, newer agents, Doras, Doxepin. There's many other drugs that are used, but they all have concerns for either people get sort of addicted to them, they have trouble getting off, or they have side effects, or they have strange sleep behaviors,
Rebound anxiety,
all kinds of issues. So we had said you could get a short course if you're in CBTI or you've already tried CBTI. That was our initial.
Okay.
And then we've had this concern brought to us by a sleep specialist that that's great, but there's no CBTI providers. She's trying to get some folks in her clinic to do sort of short CBTI. And that's what she talked about in a previous meeting. So we were like, well, what are the components that would be needed in that? So that would be more, not like a licensed mental health therapist. It would be more like a nurse in her clinic who had training and would do pieces of it, or she could do some. And then we had talked about apps in June. There was a definite no by HERC about the apps. But we felt like before we said definitely no, we should look, is there any app that's like evidence-based? There are a couple that are sort of evidence-based, but we can't really pay for them with the current codes. There's a ton of other apps, but there are a lot of them aren't even studied. It's just a really gray area right now.
So I guess my question, I'll fast. So my question is that are OHP patients unable to access sedative hypnotic medications? Like, I don't, and it's been a while, but I don't remember like ever, I remember being able to prescribe these and patients having access to them. I think that's where I'm getting caught off guard.
So what we have been told by our pharmacy colleagues is that Ambien is really inexpensive and patients can pay out of pocket. That's like $10 a month for a prescription.
Okay.
And so they're still able to access it. They're just OHP's only paying for 30 days. Some of the drugs that are used are considered mental health carve-out drugs. So if you used the Doxepin dose that is a little higher, that isn't the insomnia dose, that goes through. I think the insomnia doses are additionally, they're like 6 and 3 milligrams versus like a 10 milligram Doxepin tablet, there's no controls on. There's some concern on the pharmacy side about the newer medications in the DORA class, and I can't remember what DORA stands for. They're quite expensive. And there was just a DIRP report that was published in the last week that showed that they're probably not more effective than like Ambien. So although they're marketed as not having some of the side effects. So, and then there's also medications that you could get over the counter, doxylamine, diphenhydramine, patients use those all the time. So we could just leave our guideline the way it is, and patients are probably still accessing medications. We just don't want. We really wanted to cover the CBTI because it is, and more evidence is coming out all over there. It's super effective if you can access it and do it.
It can be done via telemedicine though, right?
Absolutely.
Okay.
In fact, the one provider that I found in the area that I send my patients to, I think is solely telemedicine.
So where are we at? Questions, concerns, continued thoughts?
My understanding still was it was an access issue still, so the medications were still only like because they couldn't get CBTI from the provider. She was in rural Oregon,
yes.
correct?
I think that is a concern in some areas, not all, but that does not negate all of the concerns regarding the medications.
Correct. Yeah. So is the short course, that's a good compromise?
Well, I think
That's what we've already done.
we've already been covering that. So the question now is, so have we already been covering the CBTI? I don't
Yes.
understand.
Yes.
So what are we supposed to be, what are we changing?
Behind you is.
So we are trying to address a concern by a provider that CBTI is not readily available and trying to outline, if you can't do CBTI, what could you do? We could also say, we don't want to change our guideline. The evidence is really that CBTI needs to be done. However, you can get it. So I think our options would be make no change, accept the staff recommendation, or send it back for more work and let us know what you want us to do.
Okay, there's our options. Adrian has a significantly furrowed brow.
No, I mean, I'm trying to, like, I think I normally don't go against like staff recommendation or whatever, but I mean,
Absolutely go.
I am like, I'm kind of thinking just leave the guideline the way that it's at. I mean, if the intention was that we are going to cover insomnia and we're going to cover insomnia treated to kind of the gold standard, then that's like CBTI. I mean, I do think that it's unfortunate and there's a real access issue, but because there's an access issue to CBTI doesn't mean that I think we should be covering sedative hypnotic medications in this space. Because the risks there are real, so.
Yeah, the testimony from Dr. Henderson was that some of the medicines other than Ambien had less side effects, but if you don't agree with that.
Well, and so I'm sorry, I did not include the DERB report because it was just published. It was not in your packet. But the bottom line was that they appear to be not really significantly better in their estimation.
Which means they just have more side effects.
And didn't you use it at a lower dose?
That was the doxepin.
Yeah. Oh,
Yeah.
okay.
That's a long, old
Yeah.
DCA, right?
Yeah, and if you use it, the dose for insomnia is a strange dose. There is an almost equivalent dose if you cut a pill in half that would be really inexpensive and would be available